I wish to welcome you to yet another online lecture that I'm giving, where in this particular lecture, we are going to talk about topographic anatomy of the hip joint. To bring you to perspective, we've been doing a series of topographic anatomy of the lower limb. I've already done that of the gluteal region, also that of the thigh, and that one we did it in two parts. Now we are looking at the third component, which is basically the fourth lecture on the topographic anatomy of the hip joint. There are yet other lectures to follow, so you can also watch out for them. Now, just as a matter of introduction, when you talk about articular system, we are referring to that system of the body that is concerned with joints. Remember, joints are important in movement, and so joints are part of the locomotor supersystem. The other components of the locomotor supersystem are the skeletal system as well as the muscular system. Now let's narrow down to joints in particular. A joint is a junction between two or more bones, at least as used in human anatomy. It's a junction between two or more bones, and they allow variable degree of movement and also degree of growth. So they allow growth, but they also allow variable degree of movement. A joint can be considered simple if there are only two bones articulating in that particular point, but can also be considered as compound if there are more than two bones articulating at that particular joint. There are different types of joints. We have fibrous joints, where the bones are joined by fibrous connective tissue. And these ones could be different varieties, such as gomphoses and syndesmosis. Then we have cartilaginous joints, where the two articulating bones are linked by cartilage. We can have primary cartilaginous joint, which we call synchondrosis, and secondary cartilaginous joints, which we call symphysial joints. Then the third variety of joint is the synovial joint, where the bones articulating there are separated by a synovial cavity, and that cavity contains synovial fluid, which is a lubricant that reduces friction. For that reason, synovial joints are usually more mobile compared to the other two types of joints that you mentioned. Now, when you talk about hip joint, the hip joint is an example of a synovial joint. Now, I want to give us just some skeleton of expectation whenever we're describing the topographic anatomy of a synovial joint. What is it that we need to bring out, even in our description, so that we are comprehensive? Perhaps to start with, we need to know where that joint is. So it's good to mention the site of the body. Where is it found exactly? And also, to add to that, we need to know which bones actually articulate at that particular joint, and just give us the major bones. After that, we need to know the classification of that synovial joint. Synovial joints can be classified from anatomical perspective based on the configuration of the articulating surfaces, the configuration of the articular parts. That's more anatomical. But we can also classify synovial joint based on the number of axes of movement. If it moves on in one axis, it's a uniaxial joint. If it moves in two axes, it's a biaxial joint. If it can move on multiple axes, then it's a multi-axial joint. That's more of a physiological classification, but very important in classifying synovial joints. After that, we need to know something about the articular surfaces, the structures which articulate. And here we give a detailed description of the surfaces that make contact in that particular joint. So the bone surfaces in particular. Sometimes there are other structures which are also participating in articulation. And so it's also okay to mention them in that particular joint. But we need a detailed description of the structures that participate in that particular joint, in the articulation of that joint. After that, we talk about stability factors. When you think about stability factors of a joint, think about the things that prevent dislocation in that particular joint, or things that limit excessive movements in that particular joint. You know that joint cannot just move 360 degrees. There's something that will limit the movement. Again, we know that we don't want to be dislocating our joints anyhow. And so there's something that prevents the dislocation. Those ones become the stability factors of a joint. We can classify stability factors of a joint, of a synovial joint, in two ways. There are those that are static factors, and there are those ones which are dynamic. The static factors will involve the configuration of the articulating bones. So you call that the bony factor. It will also involve some modifications on the capsule of that particular synovial joint, or the unique features of that capsule. You can call those ones capsular factors. And then it also involves ligaments around that joint. Understand that ligaments join one bone to another, and they act by limiting stretch. So you can call that the ligamentous factors. Bony, capsular, and ligamentous factors are basically static factors. Then the dynamic factors involve muscles, which are around that joint, and even tendons of muscles, which are around that joint. So those ones are dynamic factors. They all contribute to joint stability. After that, it is important to talk about relational anatomy. But of course, if you are realistic, it might not be necessary to mention everything that's around a particular joint. The reason why we learn this is so that we can apply it clinically. And so it's also okay to filter what is important as a relation of a particular joint, especially those ones with clinical implications. So in describing the relational anatomy, it will be good to look at the relations in 3 dimensions. So you talk about what is in front, if it's applicable, what is posterior, what is medial, what's lateral, what is superior, what is inferior. Whatever is applicable is what you talk about. Remember, the importance of learning the relational anatomy of a joint is so that we can apply this clinically. The relational anatomy influences how that joint is going to be approached during surgery. Where do we cut if you want to approach this particular joint surgically? It will depend on the relational anatomy. There are some regions you don't want to approach because perhaps they contain some important neurovascular structures. Other than that, the relational anatomy informs us on possible complications when that joint is dislocated in a particular direction. If, for example, a structure is posterior and the joint dislocates posteriorly, then that structure that's posterior is most at risk. That's why we learn relational anatomy of a joint. The next thing we learn, or we need to know, is the neurovascular supply of a particular joint, which blood vessels, and especially we look at the arteries, which arteries supply this joint. As we describe the arteries, it's also okay to mention possible anastomosis if they exist in that particular joint. Remember, anastomosis, the union of two or more vascular beds. They provide collateral supply to a particular structure. Sensory innervation to that joint is also important to mention. We just mentioned the nerves that provide branches to that joint either directly or indirectly. Then we talk about mobility or movements in a particular joint. So when you describe movements of a synovial joint, we want to know the types of movements which are there. Is it flexion, extension, medial rotation, lateral rotation, and the like? We want to know the types of movement. And if possible, you also talk about the degree of those movements. To what extent can that joint allow flexion? To what extent can it allow extension? You may not be able to know it in degrees exactly all the time, but where you know, it's good to mention. As we mentioned, the movements that occur in the joint, we usually also highlight on the muscles that cause those movements. Also, while there, perhaps there's some muscles that are key in a particular movement. They are the primary movers. Then there's some muscles which are just accessory. If that is applicable, it is also okay to highlight. After that, we talk about clinical relevance or clinical significance. Now, you may not have an independent subtitle that you've called clinical relevance, because most of the time, as we discuss all these anatomical factors, there'll be something clinical that is applicable to perhaps near all of them. However, the reason why I put this here is so that we remember that it's good to have some clinical input, some clinical concepts that you bring in as you describe the anatomy of a particular joint. Most of these clinical aspects will be related to the anatomy that you are describing. So what this anatomy that you already know, how does it apply clinically? Some people call it applied anatomy. Great. So with that in mind, I want us to use those objectives that I've given you for standard synovial joint and fill in the gaps for this hip joint that we're discussing. Let's start with the anatomical location. So this shows us the anatomical location of the hip joint. This is where the hip joint is found. So we can see it's the joint between the thigh and the pelvis, and is formed by the femur and the pelvic bone. So we now know where the hip joint is found. It's one of the major joints of the lower limb and perhaps the largest joint in the lower limb. Having said so, we can now give a classification of the hip joint. As I told you, for synovial joint, there's some concepts that we look at when we classify them. But overall, the hip joint is a synovial joint. It is not fibrous joint, it is not cartilaginous joint, it's a synovial joint. And because it's a synovial joint, it will allow a lot of movement compared to what a fibrous joint can allow or a cartilaginous joint can allow. Now we narrow down to the variety of the synovial joint that the hip joint is. Based on the configuration of the articular surfaces, the hip joint is a ball and socket variety. The ball is the head of femur and the socket is the acetabulum. So it's a synovial ball and socket joint. In terms of the number of axes that movements occur in, the hip joint allows movement in multiple axes. Therefore, it's a multi-axial joint. So if I had to put that in summary, the correct classification of the hip joint is a synovial ball and socket joint of multi-axial type. We can just say it's a synovial ball and socket multi-axial joint. Great. Third agenda is to describe the articular surfaces. We want to give a detailed description of the structures that articulate at the hip joint. There are two structures that articulate at the hip joint primarily. We have the acetabulum and the head of femur. This is the acetabulum, and that's the head of femur. I want us to begin by describing the acetabulum. So this is how the acetabulum looks like. It means cup-like. The acetabulum consists of a confluence of three bones: the ilium, the pubis, and the ischium. And these three bones usually are separated by a cartilage, which we call the triradiate cartilage. This triradiate cartilage is present more in a child, but as this child grows, the three bones fuse, and so you don't see the cartilage in adults. But in children, it will be there because the three bones have not yet fused. But that will be the triradiate cartilage separating the three bones. Radiologically, if you are to take a radiograph of the hip of a child, therefore, you will see the three bones are separated. So this is the position of the triradiate cartilage. It tells us this is actually a child. You can also see the epiphysis of the femoral head has also not yet fused with the metaphysis of the femur. They are still separate. So this is the position of the triradiate cartilage. The acetabulum is both anteverted as well as inferiorly inclined. What does that mean? Anteverted means that it's tilted anteriorly, so it faces slightly forwards. The acetabula don't face directly laterally from the pelvis. They face slightly forwards, and that is why we're able to see a plot of them, this pelvic bone being put in a neutral position. We're able to see that, so they face slightly anterior. We are saying they face anteriorly, but they also face slightly inferiorly. They face downwards. So that is one acetabulum, that's the other acetabulum. What are the parts of the acetabulum? Let's use this image. So we have what we call the lunate surface of the acetabulum. Look like a crescent moon, that is called the lunate surface. This is the lunate surface of the acetabulum. The lunate surface of the acetabulum is the articulating surface of the acetabulum. It is the part of the acetabulum that makes contact with the head of femur. And because it is the part that makes contact, it is lined by articular cartilage. Remember, articular cartilage is a type of hyaline cartilage. We usually find it in synovial joints. It's a type of hyaline cartilage that is found in synovial joints, that articular cartilage. And so the lunate surface is covered by the articular cartilage. This is the lunate surface of the acetabulum. It's the articulating surface, remember. Then we have what we call the acetabular fossa. This is the acetabular fossa. The acetabular fossa is a depression at the center or the floor of the acetabulum. This depression is non-articular. It is not making contact with the head of femur. Usually, just a small depression, It's covered by fibrofatty tissue and occasionally also lined by synovial membrane. So remember, the fossa is non-articular. It doesn't make contact. And for that reason, it does not have the articular cartilage lining it. Inferior to the fossa is this defect of the lunate surface. This defect here is what we call the acetabular notch. So it's an inferior defect of the acetabulum. This defect of the acetabulum is usually bridged by a ligament, and the ligament that bridges it is called the transverse acetabular ligament. So the transverse acetabular ligament bridges the acetabular notch, and so making the acetabulum to appear like a complete curve. Then we have what we call the acetabular labrum. The acetabular labrum is this thing here. This is a fibrocartilaginous ring that surrounds the rim of the acetabulum. Fibrocartilaginous ring that surrounds the rim of the acetabulum. It goes all around over the lunate surface as well as even over the acetabular notch. Then we have what we call the acetabular roof, acetabular floor, acetabular walls, and acetabular column. The roof is the upper part. Maybe let me use this other image. The roof is the upper part of the acetabulum, so largely on the side of the ilium. The floor is on the side of the acetabular fossa, so the bone there at the acetabular fossa is the floor. The floor separates the acetabulum from the pelvic cavity. Then this will be the anterior wall, and this is the posterior wall. How about the column? So the column is this one. This is the anterior column extending from the ilium to the pubis. That's the anterior column of the acetabulum. And this is the posterior column of the acetabulum, again extending from the ilium, but now to the ischium. So those are the columns of the acetabulum. Great, so that's acetabulum. Let's now describe the other articular surface or other articular structure. That's the femoral head. The head of femur is suspended by the femoral neck. It's an almost rounded structure there. The upper part of it is covered by articular cartilage, signifying that that upper part is the articular surface of the head of femur. However, it's not the whole head that's covered by the articular cartilage. There's a small depression that is not covered by the articular cartilage. That small depression is called the fovea capitis. It represents the region where a ligament attaches. That ligament is called the ligament, the round ligament of the head of femur, or ligamentum teres capitis, the round ligament of the head of femur. Great. This is the ligament that I'm talking about. Ligamentum teres capitis femoris, round ligament of the head of femur. Partly attaching from the acetabular notch and also some part of the fossa, and then attaching to the fovea capitis. Having said so, describe those articular surfaces, let's now look at some normal radiographic references that we use to describe these articular structures around the hip joint. We'll talk about the Iliophobic line. So the Iliophobic line is this line here, extending from the ilium, going the way to the pubic bone, superior pubic ramus. So this one here, labeled 4, is the Iliophobic Line, and it represents the anterior column of the acetabulum. Then we have the ilioischial line. This is the ilioischial line, again extending from the ilium all the way, then going to the ischium there, the one labeled 5. It represents the posterior column of the acetabulum. Remember, this is an AP view of the hip joint, and so things are superimposed. But those are the radiological reference lines. We have the acetabular floor. This is the acetabular floor. Almost appear very thin at that point. And from there, we can see that separated from it a thin bone that then empties, or rather on the middle side, we have the pelvic cavity. So that's the acetabular floor. Now, just below that floor is this thing here, which looks like a teardrop. We actually call it the pelvic teardrop sign. Represents some superimposition of some bones and lines at the floor of the acetabulum. Then we have the acetabular roof and the acetabular sourcil. So the acetabular roof is the upper part of the acetabulum. The acetabular sourcil refers to this part labeled 3. It is in the roof, but the sclerotic part of the acetabular roof. Sclerotic means slightly bright radiologically. If you look at it from this particular point, that region is the brighter zone, representing some cortical bone. And so that is the sclerotic part, the acetabular sourcil, level 3. We have a line which we call Shenton's line. Shenton's line checks for continuity of the inferior femoral neck and the inferior margin of the superior pubic ramus. Now follow that pointer. This is the fair line, that fair line there, and it should be a nice curve between the inferior margin of the superior pubic ramus and continue smoothly into the inferior part of the femoral neck. That is the Shenton's line. That line should be a smooth curvature. And so if it is interrupted, then you know that there's something wrong with that particular hip joint. Maybe a dislocation, maybe a fracture, something wrong. We have what we call the Sharp's angle. The Sharp's angle measures the acetabular inclination. Let me show it here. So we want to know how much is the acetabulum inclined. The reference lines, that is the reference horizontal line. Then you take the margins of the acetabulum. You put another line there. So the angle here is the Sharp's angle, determining the acetabular, the degree of acetabular inclination. So if this angle is more than 45 degrees, then most likely that acetabulum is not deep enough. It is dysplastic. This angle should be less than 45 degrees. Then we'll consider that acetabulum to be deep enough and also well inclined. The other angle that we can also use to measure the acetabular inclination is what we call Tunis Angle. Tunis Angle is done like this. So you get a horizontal line that passes through a tangent on the upper part of the femoral head. And then we get the inclined line that touches on the two margins of the acetabular sourcil. So the lateral and the medial margin of acetabular sourcil align there. This is the angle we're talking about. That angle should be between 0 to 10 degrees. So if it's larger, like in this case, again, it tells us more about dysplasia of the acetabulum. That acetabulum is not deep enough, so perhaps that joint is unstable. Then we have what we call the femoral neck shaft angle. Maybe let me just show you first using a drawn image before I show you the radiological part. So we know this is the head of femur, this is the neck, this is the shaft of femur. We can see that the neck of femur is not in straight line with the shaft of femur. So long axis through the neck and long axis through the shaft will give us an angle. Now the lower angle is what you're looking at. This is the femoral neck shaft angle. It measures the angle between the femoral neck and the shaft, that inferior angle. Normal one in adults about 125 to 140 degrees. Could be larger in children, but that's the one in adults. So radiologically, that's how we'll get it still. We measure this lower angle there. There's some terminologies we can use. If this angle is not normal, you can check on what is coxa valgus and what is coxa vera. We have what you call femoral acetabular joint width. Femoral acetabular joint width measures the interbone distance between the femoral head and the acetabular margin. Don't confuse it with the Tunis angle. So here we're just looking at the joint width. Now don't assume that when you see that gap, that it's usually just a space. Remember, this is radiograph using X-rays. And so it will only give us perhaps the appearance of denser structures like bone. But we have cartilage there. The articular cartilage is radiolucent, and especially with the radiation that's used to acquire this image. And that's why it's not visible. So when you see a thin gap, it just tells you that the cartilage is thin. And when you see a thicker gap, it just means that the cartilage is thick. So we do this to evaluate the degree of perhaps joint degeneration as we grow. Last but not least, we have the femoral anteversion angle. This is a bit hard to show radiologically, so let me just use a drawn image. When we take femur and put it on a flat surface with the posterior part on top of the flat surface, and so the two condyles make contact, we'll notice that the head does not make contact with that flat surface. Why is that so? The head does not make contact because the neck of the femur is anteriorly inclined. So there's some anterior deviation of the head of femur, head and neck of femur, with respect to the plane of the femoral condyles. And so that angle of anterior deviation is what we call the angle of femoral anteversion, or the angle of femoral torsion. The femur is torted anteriorly, slight rotation, which makes now the head tilt anteriorly with respect to the plane of the condyles. So the angle of femoral torsion the same as the angle of femoral anteversion. Normal is about 10 to 15 degrees. Remember, the acetabulum was also anteverted, facing anteriorly. So don't make a wise assumption that now, because the acetabulum is facing anteriorly, that the head and neck of femur should face posteriorly. It will sound logical, but that's not true. The fact is both of them face anteriorly. And you want to ask yourself, why is it that both of them are facing anteriorly? It gives the femur a wider degree of freedom of movement, especially for medial rotation. That's the whole purpose. Great. Now let's look at the next thing. We look at the stability factors. We discussed that when you look at stability factors, you look at static as well as ligamentous factors. Let's start with the static stability factors. We had classified the static stability factors as bony, capsular, and ligamentous. And we'll see them with that light. Let's start with the bony factors. The bony factors here refer to how congruent are the bones which are articulating here. Now, the head of femur is fitting nicely, of course not completely, but a big part of the head of femur fits nicely into the acetabular socket. More than half of the head of femur enters into the socket of the acetabulum. That makes this joint very stable, even without any other factor. And so the bony factor is a key factor, perhaps the most important factor in hip joint stability. However, the bone does not just act on its own. That acetabulum, the margin of the acetabulum has the acetabular labrum, and that labrum enhances this bony factor still, because it even deepens the acetabulum even more, so that the acetabular labrum embraces the femoral head and so restraining it within the socket. So the bony factor is enhanced by the acetabular labrum, here, therefore making this bony factor an important stability factor for the hip joint. Let's say something about that acetabular labrum. We had mentioned that a fibrocartilage rim, it's a fibrocartilage ring that is on the rim of the acetabulum all around. This fibrocartilaginous rim has the following function. So one, we agree it stabilizes the femoral head within the acetabular socket, so it restrains it. Apart from that, we see that this particular labrum also facilitates the normal maturation of the acetabulum. This is especially when you look at children growing from infancy into early childhood. The presence of the labrum helps in normal maturation of the acetabulum. We also know that this labrum seals synovial fluid within the joint because it's making contact with the head of femur. And so it kind of seals the synovial fluid within the joint so that there's no significant extravasation of fluid from inside the joint outwards. The labrum also enhances the vacuum effect that is usually found within this joint. So the joint has some vacuum effect because of the presence of the labrum as well as the configuration of the articulating surfaces. Some vacuum effect, and that vacuum effect also enhances stability because it makes the head now to continue to stick in the socket. Last but not least, the labrum is also having proprioceptive functions. Maybe you don't know what is proprioception. Proprioception basically the sense of position, the sense of spatial orientation in space. You can be seated, and even without you opening your eyes, you are aware that you are seated. And with your eyes closed, you can still stand, and you are aware you are standing. You can move your thigh backwards and forwards, and you know where your thigh is without confirming your eyes, because you are aware of that position. So a number of things are innervated with the receptors for proprioception to give information regarding joint position. And this labrum is one of those structures that contain receptors which are innervated to give information regarding joint position. So as the femur touches it, the body knows the position of the hip joint. Great. Apart from just talking about that bony factor, you've realized that the depth of the acetabulum is a very key factor in determining hip joint stability. For that reason, there are ways in which we usually even estimate how much is the acetabula covering the head. We call that concept acetabular coverage. The normal one is that the acetabulum will cover, okay, like more than half, and usually it's about 3/4 of the femoral head. That's the normal one. We can determine, therefore, the degree of acetabular coverage using some measurements, and radiologically, I want to share with you 2 measurements that can be used. They're not the only ones, but they're easy to do because you can get them from the AP radiograph of the hip. This is what we call the lateral center edge angle of Weiberg's. The lateral center edge angle is measured like this. We'll just look at the lateral acetabular coverage of the femoral head. The lateral acetabular coverage of the femoral head on an AP radiograph of the hip. So how we do it, you take the center of the acetabulum, and that will determine your vertical line. Sorry, the center of the femoral head, and that will determine your vertical line. Then you draw another line now at the lateral edge of the acetabulum. So this angle here is what we're calling the lateral center edge angle. The normal one will be about 25 to 35 degrees. Some people go even up to 40 degrees, no problem. Understand that if this value is less than 20, that joint will be a bit unstable because the acetabulum will not be covering the head nicely. It is inadequate coverage. The other measurement we can use to also determine acetabular coverage is what we call the femoral head extrusion index. How much of the femoral head is extruded? We do this by measuring a percentage of the femoral head that is outside the acetabular roof. Percent of the femoral head that is outside the acetabulum. Now, this is how we do it. So we take 2 lines. Line B is the whole of that horizontal for the femoral head. And line A is the part of line B that is outside the roof. So you take A, line A, distance A over distance B times 100 to get the femoral head extrusion index. With that, having said that 75% of the head is in the acetabulum, we therefore expect that this measurement here should be less than 25%. So the femoral head extrusion index should be less than 25%. Okay, that is much enough about the bony factor. And we've talked more even about the acetabulum and some measurements to do. Let's look at the other two static factors, the capsular and ligamentous factors. The capsule of the hip joint is very strong and it's also dense. That also contributes to stability of the joint because it's a strong capsule, it's also a dense capsule. This capsule is attached to many parts, and I want you at your own time to just look at an atlas and see where the capsule of the hip joint is attached, both proximally as well as distally. You can get a nice description from a textbook, but also you can look just at an atlas and figure out where the sites of capsule attachment of the hip joint. I'll not go into that one. Anyway, the capsule is reinforced by some ligaments, and I'll mention three major ligaments that reinforces the joint capsule of the hip. We have the iliofemoral ligament. This ligament has the shape of an inverted Y. This is the ligament. It has the shape of inverted Y, with the stem of the Y being superior and the two arms of the Y being inferior or inferolateral. The ligament lies anterior to the hip joint, and perhaps the strongest of the ligaments we're going to talk about. This ligament lying anteriorly, it will limit hyperextension of the hip joint. So superiorly, it's attached to the anterior inferior iliac spine. Maybe this one shows it better. Anterior inferior iliac spine, that's the superior attachment. The inferior attachment is along the intertrochanteric line. Having said that's Y-shaped, it means it has two bands. There's a medial band that is almost vertical. And there's a lateral band that is relatively inclined. So that's the iliofemoral ligament. So that region will be relatively thicker and perhaps almost deficient in that particular region. Remember, it limits hip hyperextension. Then we have the pubofemoral ligament, the one in green, if I get that color right. As the name suggests, it comes from the pubic bone and goes to the femur, so we call it pubofemoral ligament. It's attaching to the pubic bone there, and usually the ligament is relatively inferior, and so largely it limits hip abduction. Last but not least, we have the ischiofemoral ligament, which is broader and is more posterior. This is the ischiofemoral ligament. It's described to have multiple parts, but we'll not go into the parts of the ligament. It is arising from the ischium and inserting to the femur, but more posteriorly. That's why we see it from the posterior view. Great. Those are the three major ligaments of the hip joint. But there are other ligaments of the hip that I also want to talk about. The transverse acetabular ligament is this ligament that bridges the acetabular notch. So this is a thick ligament, but its free margin, the peripheral part, is continuous with the acetabular labrum. The attached also with this acetabular labrum. Remember, acetabular labrum goes all around. Now, when it bridges that particular notch, there's a small gap that it leaves inferiorly. That foramen that it leaves inferiorly or deep to it, you can call it acetabular foramen, allows for passage of vessels and nerves which go to the head of femur through this other ligament that I'm going to talk about. So here we see that particular foramen there. which allows for the passage of nerves and vessels which go to the head of femur. The other ligament is what we call the ligamentum teres capitis. Ligamentum teres capitis, or others called the round ligament of the head of femur, attaches from the acetabular notch and partly the fossa of the acetabulum, and it inserts into the fovea capitis of the femoral head. That's the round ligament of the head of femur. The blood vessels and nerves that I mentioned pass through that ligament as they go to the head of femur. So those are the other ligaments I want to talk about in the hip. And so that summarizes for us the static stability factors of the hip joint. Now let's talk about the dynamic stability factors of the hip. When we talk about dynamic factors, we are talking about the muscles that surround the joint and even their tendons. So basically, we can mention all the muscles really, but some muscles are key, and I want to talk about those key ones. The iliopsoas is a key dynamic stability factor of the hip. It lies anterior to the joint and actually makes contact with the capsule of the joint, except that there's a bursa that separates it from the capsule. What's a bursa? A bursa is a fluid-filled cavity, fluid-filled pocket that reduces friction between a tendon and a bony surface, or a tendon and a tendon. And so we have the psoas bursa, which lies anterior to the joint, but posterior to the iliopsoas tendon, reducing friction between the two. It's the trochanteric fossa. Great, those are the two key tendons I wanted to mention, but of course, any other muscle and tendon around the hip will contribute to dynamic stability factor. So think about the gluteus medius, gluteus minimus, the 6 small lat rotators. They all contribute in a way to the hip stability. Having talked about that, let's now go through relational anatomy of the hip joint. So we'll talk about the important structures, and we'd already understood why it's important to know the relational anatomy. Anteriorly, what is in front of the hip joint, it will be the muscles that form the floor of the femoral triangle, as well as the contents of the femoral triangle, largely. So remind yourself, those structures, they're the ones which are in front of the hip joint. How about superiorly? We have the reflected head of rectus femoris, as well as the gluteus minimus muscle, also being on the upper part of the joint. And then below, we have the tendon of obturator externus, as we've mentioned. Pectineus also partly is an inferior relation of this particular joint, and that's why it's able to adduct the joint. Posteriorly, we can talk about the lat rotators, the 6 small lat rotators. We can talk about them, well, apart from perhaps piriformis, and then we can talk about the sciatic nerve. Or we can put it this way, those infrapiriformic structures. Remember the pins, most of those are actually posterior to the joint. But of course, you're mentioning the main one here, sciatic nerve. Great, that is relations of the hip joint, we can use that information to apply what would then happen. So you can apply that information clinically in dislocations or in approach to surgery. Let's talk about the neurovascular supply to the hip joint. We start with the nerve supply. The nerves that go to the hip joint are the superior gluteal nerve, gives a branch there. Nerve to quadratus femoris also gives a branch to the joint. And femoral nerve may give direct or muscular branches, which are indirect to the hip joint as well. It is not hard to talk about innervation of a synovial joint, really, because of some concepts that I want to teach you shortly. But look here, so that's the femoral nerve. Okay, maybe we start here. So this is the piriformis muscle, that's the superior gluteal nerve. Remember, come from the upper part of the greater sciatic foramen. It goes to gluteus minimus, gluteus medius, tensor fasciae lata, and now we add it as a branch to the hip joint. We've mentioned nerve to quadratus femoris. So this is the quadratus femoris muscle. And that's the nerve to quadratus femoris. It's one of the infrapiriformic structures. It supplies the quadratus femoris. It also supplies the inferior gemellus. And now we've added also the hip joint. And here we see the femoral nerve in the groove between iliacus and psoas major. The femoral nerve ramifies into many branches. In the previous class, we talked about muscular branches, cutaneous branches. Now we are adding branches to the hip joint. Now, we also have the obturator nerve. This is the obturator nerve. Remember, obturator nerve has anterior division and posterior division. Remember that the anterior division gives a branch to the hip joint. Posterior division gives a branch to the knee joint. And that was clinically important in the fact that you can have pain referral from these two joints. Now, I was telling you that remembering innervation of a joint should not be a difficult thing if you know what Hilton's law states. Hilton's law states that the nerve supplying muscles extending directly across and acting at a given joint not only supply the muscles, but also supply the joint as well as the skin around that muscle. So if you know the muscles that cross this particular joint, the nerves that go to them most likely will supply this particular joint. And that Hilton's law, well, been very little dispute about it. It is largely true. And so you can take that to the bank. So if you don't know any nerve, just look at the muscles around that particular joint, look at the nerve supply, mention those nerves. You'll most likely be right. Now we can talk about the blood supply to the hip joint. The blood supply to the hip joint is very important also because it has some clinical implication. The blood vessels that are around the hip joint, it's important to know where they come from. Largely, they come from two anastomoses, the trochanteric anastomosis as well as the cruciate anastomosis. But remember, those anastomoses come from other arteries. So I want us to approach it this way. We'll first describe the anastomosis around the hip joint, and then we'll see how these vessels then eventually take blood to the head or femur. Okay, remember that we have what we call the common femoral artery. which gives you deep femoral artery, profunda femoris, and superficial femoral artery. The deep femoral artery will then give us the two circumflex femoral arteries, lateral circumflex femoral artery and medial circumflex femoral artery. Those circumflex femoral arteries are called so because they go around the femur, one medially, one laterally. The medial circumflex femoral artery has two branches, the ascending branch of the medial circumflex femoral artery and the transverse branch of the medial circumflex femoral artery. The lateral circumflex femoral artery has three branches, which we want to talk about. The ascending branch of the lateral circumflex femoral artery, the transverse branch of the lateral circumflex femoral artery, and the descending branch of the lateral circumflex femoral artery. The transverse branch of the lateral circumflex and the transverse branch of the medial circumflex contribute to the cruciate anastomosis. The cruciate anastomosis is located at the level of the lesser trochanter, which is this one. So they're located at that level. Those two transverse branches of the circumflex arteries contribute, but they're not the only ones. Remember, it's cruciate, so we need a plus. Those are the arteries that come from medially, the transverse branch of medial circumflex, laterally, the transverse branch of the lateral circumflex. Superiorly, we have the branch of the inferior gluteal artery, and from below, we have the ascending branch from the first perforating artery. Those ones contribute to the cruciate anastomosis. Apart from the cruciate anastomosis, we have the trochanteric anastomosis found at the level of the trochanteric fossa. The trochanteric anastomosis contributed largely by the ascending branch of the medial circumflex and the ascending branch of the lateral circumflex, also by the superior gluteal artery, and sometimes also the inferior gluteal artery. So those are the two major anastomoses around the hip joint capsule there. From this anastomosis, we can now have arteries which go to the head of femur. Now, I know I've mentioned many arteries that contribute to the anastomosis, but there's something also key to mention. Even though there are many arteries which go to this anastomosis, most of that blood is contributed by the medial circumflex femoral artery. And so the medial circumflex femoral artery is a major artery that contributes to the blood supply to the hip joint. Yes, there are many vessels contributing to anastomosis, but much of that blood is contributed by the medial circumflex femoral artery. So it's the most important artery. Anyway, from the anastomosis, remember there's a capsule of the joint that comes and attaches. From that capsule that attaches to the joint, there's some internal reflective fibers which come from the neck side towards the head of the femur. We call them retinocular fibers of the capsule. So they're internal reflections of the capsule of the joint towards the head of femur. Those retinocular fibers carry with them some arteries, which we call retinocular arteries. These retinocular arteries arise from the anastomosis. The retinocular arteries contribute significantly to the blood supply of the head of femur. In adults, contribute almost the whole head of femur supplied by the retinocular arteries. In children, maybe not the whole of it, but still a good part of it. but in adults, almost the whole head is supplied by the retinocular arteries. So we can say this, that the head of femur receives multiple sources of blood supply, primarily by the retinocular arteries, which come from the anastomosis around the hip joint. So the retinocular vessels are the chief source of blood supply to the head of femur, especially in adults. But what are the other sources? So let's mention one. We mentioned about the ligamentum teres capitis attaching at the fovea. Ligamentum teres capitis traverse some vessels that go to the head of femur. We call them the acetabular branches of the obturator artery. So it's the obturator artery that gives you that branch, which you call the acetabular branch of the obturator artery. It enters through ligamentum teres and so go to supply the head of femur as well. In children, this vessel will contribute to a big part supplying the head of femur. But in adults, that vessel only supplies the fovea. So it is insignificant in adults, but it is very significant in a child. The third minor source of blood supply to the head of femur is by the nutrient artery that enter through the diaphysis of femur. Well, if you understand that femur is a long bone, so it has a diaphysis, and that diaphysis receives a nutrient artery. The blood that enters through the nutrient artery may still reach the head of femur, of course, through the bone trabecular system. So that is also another source of blood supply to the head of femur. We can say it's very significant if you understand that the diaphysis, the nutrient artery, enters way far away from that head. Okay, I hope you now understood the blood supply to the head of femur. Now think about clinical implications of that in an adult vis-a-vis in a child. This image captures for you the vessels. You see this, the capsule there. And then there are internal reflective fibers that carry vessels. So these are the retinocular arteries, like that one. That's a retinocular artery. There are internal reflections of the capsule, but they carry vessels with them to the head of femur. Then that is the acetabular branch of the obturator artery entering through the acetabular foramen, and then following the ligamentum teres to the fovea capitis. I've told you that even though we're talking about anastomosis, medial circumflex femoral artery is the chief contributor to the blood supply of the head of femur. Now let's talk about hip joint movements. Hip joint is a multi-axial joint, and that means that it will allow movement in multiple axes. Having said so, we can describe 3 degrees of freedom. There's the axis for flexion and extension, axis for adduction, abduction, axis for internal rotation and lateral rotation. If you are to talk about flexion and extension of the hip, the flexion and extension of the hip will occur through a transverse axis, a mediolateral axis. Flexion is much permissive than extension at the hip joint because the extension is limited by the iliofemoral ligament, limited by the tendon of psoas major, limited by the rectus femoris. But flexion is permissive to a big degree. And these measurements that I've given there are assuming you're starting from a vertical neutral position. So if you start from a vertical, you can only go about 10 to 20 degrees backwards in hip extension. Can you go up to 110, 120 anteriorly in hip flexion. So which muscles cause flexion at the hip? There are many muscles, but perhaps the chief one with the iliopsoas unit, assisted now by rectus femoris, sartorius, tensor fascia lata, pectineus, and the like. Which ones cause extension of the hip? Principally, we have the hamstring unit as well as the gluteus maximus muscle causing extension at the hip joint. Of course, remember that the adductor magnus has an hamstring part which can also then extend. How about abduction and adduction? Abduction and adduction occurs through an anteroposterior axis through the femoral head. Adduction is caused by the adductor muscles. So remember the medial compartment of the thigh, the adductor compartment, those are the muscles that will cause adduction at the hip joint. Abduction at the hip is caused by gluteus medius, gluteus minimus, tensor fascia lata, and sartorius muscle. Now remember, hip abduction is a key movement in also stabilizing the hip during walking. We'll talk more about that and the clinical implications. Medial rotation and lateral rotation are also movements that are occurring at the hip. Now, I want to leave it to you to fill in which muscles actually cause medial rotation at the hip joints. We've mentioned them in the previous classes. Some muscles in the gluteal region, some muscles in the anterior thigh that can cause medial rotation at the hip joint. Also, the lateral rotators of the hip, remember them? They're largely muscles of the gluteal region, the 6 small. Again, I leave it to you to fill that gap. Now, those are the movements that are permissible at the hip. Based on how the hip is configured, it has limited capacity for translational motion, either in the anteroposterior, in the transverse, or in the vertical planes. So translational motion is limited, but motion around axis are permissive. And those are the ones I've given you. Now let's finish the anatomy of the hip joint by talking about clinical relevance or clinical significance of the hip joint. We've been mentioning some things. I told you that this need not to be a separate subtitle because you need to consolidate the information with the anatomy. And so sometimes it's okay to just mention applied anatomy as you describe. But let me just bring to light some concepts which are clinical based on the anatomy described. Look at this image. We are seeing somebody who is facing away from us. So the right lower limb is on the ground supporting, and the left lower limb, as we can see, is lifted off the ground. And because of that, we can see that the pelvis has tilted down on the side that is lifted up. That pelvic tilt is not a normal one. It is because of some injury that this person may have had. That tilting of the pelvis downwards is called the Trendelenburg. So if it's in a test, you call it Trendelenburg test. So that's a positive Trendelenburg test. If the person is walking and doing that, then you call it Trendelenburg gait. How does it come about? This is because of the integrity of abduction, the efficiency of abduction of the hip. Now look at the normal one first. If this limb is on the ground, like this patient's limb, and this limb is off the ground, like this patient's limb. There is tendency of this pelvis to fall down. Now, to prevent it from falling, the contralateral hip abductors contract to stabilize this hip so that it doesn't sag on the side that is lifted. Remember, the contralateral hip abductor is the one which contract, so that we don't have significant tilting of the pelvis when you lift your limb off the ground. So the pelvic tilt should be very minimal if the limb is lifted off the ground. However, if the hip abductors are not functional, let's say gluteus medius and minimus are paralyzed because of some injury to the superior gluteal nerve, what would happen? The muscles cannot contract with strength. And so when you lift the limb off the ground, the pelvis cannot be stabilized. It will sag down. And that's what we call a positive Trendelenburg sign. There'll be a lot of sagging on the side that is supporting, the side that is lifted off. Okay, so think about what would give you a positive Trendelenburg sign. One of them would be paralysis of the superior gluteal musculature, because perhaps you've injured the superior gluteal nerve or it's affected by maybe poliovirus. But there could be other causes of positive Trendelenburg sign. You can now check them out. The other thing I want to discuss is fracture of the femoral neck and its implication on the blood supply to the head of femur. So this image shows us a fracture of the femoral neck. We don't know whether there's a lot of dislocation because we're just looking at one view, but at least we confirm there's a fracture. When there is fracture of the femoral neck, the retinocular fibers and the retinocular vessels are at risk. If you have a fracture with dislocation, there's a risk of injury severing the retinocular arteries that supply the head of femur. Considering that the retinocular arteries are the chief source of blood supply to the head of femur, especially in adults, if you have a fracture dislocation of the femoral neck, it puts the retinocular arteries at risk of injury. If they're injured, it means that you're going to significantly affect the blood supply to the head of femur. So what will be the outcome? The femoral head may actually die off because of lack of blood supply. And that is what we call a vascular necrosis. So this head of femur may undergo a vascular necrosis in adults if you have a fractured neck of femur because of significant cutoff of blood supply to the head of femur. You may not have a similar phenomenon in younger people. Why? Because in younger people, the artery that enters through the ligamentum teres capitis supplies a big part of the head. So it might prevent the head from undergoing a vascular necrosis, death because of lack of blood supply. It may prevent that because it's significant. But in adults, this only supplies the fovea, so it relies purely on retinocular arteries and perhaps the diaphyseal artery, which is not very significant. And if you have fractured neck, anyway, it may also be affected. Right. The other thing I want to talk about are some, well, look at these radiographs before I tell you what I'm talking about. Look at the head of femur. Look at the acetabulum. What is wrong about this hip joint and what is wrong about this hip joint? Think about it before I tell you. Okay, so I hope you've checked and seen that there's some dislocation. The head of femur is not in the acetabular socket. Look, this is the acetabulum. This is the acetabular roof with the sourcil there. This is the acetabular floor. That's the pelvic teardrop. This is the iliopubic line, anterior column of the acetabulum. Ilioischial line, posterior column of the acetabulum. Those ones look intact, fine. But there's something that is wrong. Look at the Shelton's line. The inferior margin of the superior pubic ramus does not form a continuous arc with the inferior margin of the femoral neck. There is dislocation. How about this one? Same scenario. The head of femur is down here. This is the acetabulum. Again, that's the pelvic teardrop, which you also see here. This other side is okay, but this one, this is the pelvic teardrop. That's the iliopectineal line, normal. Iliopectineal line, sorry, ilioischial line, normal. Acetabular floor looks fine. But Shelton's line, not okay. Disrupted. So these are dislocations. I'm not teaching radiology, and so you don't have to insist on which dislocations are they. But the first one is a posterior dislocation of the hip, commonly occurring as dashboard injuries in road traffic accidents. It will occur mainly when the hip is flexed. And so if you get a dashboard injury, the knee is knocked with the posterior force, it will make the head of femur leave the socket to go posteriorly, putting the neurovascular structures around the hip joint at risk of injury, both even the ones in the anterior as well as the ones posterior. This other one is an inferior dislocation of, an anterior dislocation of the hip, except usually an anterior dislocation, it will go anterior inferior. We don't have to know why this is anterior, why that's posterior. That's not the scope of this particular lecture. The other thing I want to talk about as clinical aspect, remember that the psoas major arises from the lumbar vertebra anteriorly, and it goes all the way to the lesser trochanter. That's where it inserts. Psoas major is usually covered by a capsule, again, or fascia that extends from the lumbar vertebra all the way to its insertion at the lesser trochanter. Now, in some parts of the world, TB spine is a common disease. And even if it's not TB spine, infections are basically common in some parts of the world. If there's some infections, and let's put it to be TB in this case, if there's some TB infection of the spine with some abscesses, those abscesses can track beneath the fascia of psoas major from the lumbar spine, can track down all the way to the anterior part of the hip joint, because the psoas major extends all that extent. So that abscess can track down all the way and even enter the psoas region around the psoas bursa, so it can even be anterior to the hip. You can have infection spreading all the way from there to the hip. Now, why is it spread to the hip? Because the psoas bursa may sometimes also have communication with the hip joint. And so through that, infection can reach the hip. Great, so that's what I want to mention as part of clinical relevance. The others that we mentioned within the main lectures we discuss in the other parameters. So I will stop there with the topographic anatomy of the hip joint. I hope you've understood. We've used this opportunity also to just describe what is it that we need to articulate when we describe the topographic anatomy of any synovial joint, so that further, when you're going to discuss the other synovial joints, we don't have to really look at those concepts again in detail. We'll just now fill in the gaps. So we will stop there. The next class that you're going to have is on topographic anatomy of the knee joint complex. Thank you.